Welcome to the Digital Orthopedics Conference's COVID-19, the Orthopedic Response Virtual Summit. And for those of you coming from the previous session, thank you for staying with us. We have definitely had some challenges with the platform, but overall, I think you'll find that every session is different. So just because one doesn't work, the others may work very well. We're very lucky and fortunate to have Lundy Campbell join us today. Professor Campbell is the chief of cardiothoracic anesthesia at the University of California, San Francisco. He is also, interestingly, a critical care physician managing the ICUs and obviously an anesthesiologist, and with a strong interest in global health, and does work both in Central America and in elsewhere in the world. So very tuned in to the problems that are and how COVID-19 is impacting not just orthopedic care, but care in general. So we've asked him to come to join us because there are certainly issues that as orthopedic surgeons and anesthesiologists we share and we need to think about together. So he's going to touch on those issues as well as understand the implications that a COVID patient has for the anesthetized patient, because it's not your regular everyday patient. So with that, welcome, Dr. Campbell.
Thank you so much, and thank you for this opportunity to speak to you today. Because of my interest in critical care and also in global health, I want to talk about that. Let's see if my slides are.
Are your slides not moving forward?
No.
Try refreshing your screen real quick. We will lose Lundy for Dr. Campbell for 1 second, and then he's going to come right back, and hopefully we'll be able to make the slides work. It worked great a second ago. One of the great opportunities we have at UC is to work with some of these extraordinary people, Dr. Campbell being one of them with a tremendous amount of experience. So you're back, and now we need you to bring up your slide deck again.
Yes.
And I'll make that full screen for you.
Okay.
Is that working? You have to click on the PowerPoint deck. Did you click on the PowerPoint deck? Yeah.
Interesting. It's not really moving for me. Technology.
So it's funny because it worked great a second ago. So why don't you do this? Why don't you email me that deck, and maybe we can get started separately. Gosh, it's terrible when the technology doesn't work for you. There you go.
Okay. So if I keep it up here, I can move it. Okay, this will work. Okay.
All right.
So I wanted to say that ultimately with COVID-19, like I said, I have this strong interest in global health. We are all now resource poor countries. I've spent a lot of my time in what we would consider to be resource poor countries, where they don't have much equipment, and this pandemic has put us all in that situation. So with that in mind, I think that there's some things that we really need to talk about. That how do we take care of patients in that setting? And really the two things that are the two key points that come up with that is basically do only what is necessary, only the procedures that are necessary, and only what is truly necessary for that patient. And then the other key point is to plan ahead. And that'll be a thing that I'll come back to multiple times in this talk. So some general considerations about patients with COVID. What we want to do is really minimize the risk to personnel that are taking care of these patients. We also want to minimize the risk to other patients that are in the hospital or around these patients, because clearly in every hospital there's going to be a subset of patients that are going to have COVID, and then there's going to be a subset of patients that are not going to have COVID. And how do we keep them from being infected? We are looking to really increase our ICU capacity, and that's a limiting factor for most every hospital. And then I'm going to talk briefly about some ICU management issues. So how do we minimize risk to personnel? Ultimately, we want to avoid anything that causes an aerosol generation. We know that COVID is basically droplet precautions, probably is mostly transmitted via droplets. There are some thought that maybe it's transmitted a little bit via airborne, but anything that can cause an aerosol generating procedure, we really want to avoid those. That can be things like putting a patient on non-invasive ventilation because you don't have a protected airway, you're giving positive pressure to the airway, and that's going to cause aerosolization of those droplets, and people nearby can breathe those in. Also, things like bronchoscopy, those kind of procedures can really cause a problem. Another thing that's very important is we want the most experienced personnel only that are really taking care of these patients, and only the most necessary personnel that are taking care of these patients. One of the things that we've really instituted is not having trainees involved in the care of these patients, because once you take somebody who cannot establish an airway rapidly or establish intravenous access rapidly, then they just have more time to be exposed to that patient in whatever situation they're in. So very important to put the most experienced and necessary personnel only. Now, clearly that has some other implications, because if you're putting your most experienced and necessary personnel on the front lines, those are the people that are going to get hit the hardest. And so if things get really out of control, you're going to start to lose some of those most experienced personnel. So that's, it's kind of a double-edged thing here that we're looking at, because how do you protect the personnel in that situation? PPE is super important for these people. How do we make sure that we have enough personal protective equipment for these people to be in and working with these patients? There's been kind of a run on people trying to wear PPE. I've seen physicians that are not even seeing patients walking around with N95 masks in the hospital. We personally consider that to be a waste. And we can talk more about in the questions if people have some questions about how do you protect your PPE in a sense. How do you keep that PPE to be useful for the most patients on the long range? As far as establishing airways, we use what we consider to be a rapid sequence intubation under most circumstances. So rapidly getting an endotracheal tube into a patient as quickly as possible, minimizing mask ventilation, anything, positive pressure ventilation with a mask that we could potentially, again, cause aerosolization of these airway particles. That has to be tempered with what's going on with the patient. If you have a patient who's very sick and has, like a low ejection fraction, then, you may not be able to do a rapid sequence intubation on that patient and have them survive. So there has to be some back and forth on that. And then again, as I said, plan ahead. So by planning ahead, you can avoid having a crash intubation on a patient. So we may intubate patients earlier than we otherwise normally would, because I know once we get to a point where now this patient's in extremis and I've got to go in there and intubate them, I don't have the ability to do it in a much more controlled fashion, which may put me or other people at risk. I also want to minimize the risk to other patients. How do we do that? So basically, I want to reduce the hospital census as much as possible. Now, that's caused a lot of consternation between, the economics of that. Surgeons definitely have patients that want to get procedures done. I totally sympathize with that. These patients need to have other procedures done. And we try to say, let's take care of the most emergent cases that we have to do. Somebody has a open femur fracture, that definitely has to go to the operating room and be done. But somebody that can have a case that you can sit on for a month, then absolutely wait. So postponing these non-emergent surgeries is very important to minimize risk to those patients as they come in. And I think it's important to tell your patients, if you're a practicing physician, why we are not scheduling your case. And it's not because, I mean, it's both because we're trying to minimize or reduce the hospital census, but we are trying to protect you from getting injured or getting COVID. You know, the hospital is probably the epicenter of where all the COVID is going to exist. So staying away from it if you can is the best possible thing to do. Patients that are in the hospital, we really want to reduce hospital transports, especially up patients that are COVID positive, or if they're undergoing investigation to see if they are positive. So the more we transport those patients around the hospital, the more we spread or potentially spread virus throughout the hospital. So we really want to reduce hospital transports, only take patients to the CT scanner, for instance, if it's absolutely necessary. Patients need protective equipment as well. So we need to have PPE for patients. Usually that does not mean an N95 mask for them, but that might mean putting on a regular operating room mask so that these patients can have, so that they're not, if they are potentially having airway secretions, it's not going everywhere. And then, as I talked about, the economics of reducing the hospital census is a consideration that, you know, it doesn't go away. It is something that we have to just address at least. Another key issue is, how do we increase ICU capacity? Obviously, reducing census within the ICU is important, but we do need to think about what other non-ICU locations can we use to bring on and increase our ICU capacity. Is that the operating room, the recovery room, the emergency room? Those places we can increase ICU capacity. Something to consider, though, is when we are in an ICU room, the best ICU room we can have for these patients is in a negative pressure ventilation room, where basically if I stand outside that room, air is rushing into the room, not out of the room. So I'm more protected when I'm outside the room. Operating rooms are the exact opposite. They are positive pressure rooms. They're designed to keep the patient in the room in a sterile environment and blow things out of the room. That's great under normal circumstances. That's horrible if that patient is basically working as in an ICU in that environment, and I've got a patient who's COVID positive, because that's going to potentially blow virus out into the rest of the hospital, certainly into the hallways around the operating rooms. PACU is basically just is not positive or negative, and the same with the emergency room. But those are considerations that need to be used. We like the operating room environment because there are ventilators in there. We're used to operating in there, and we can work in there easily. But that positive pressure environment there can be very detrimental. And then, how do we increase ICU capacity from the ICU staff? We have to have physicians, we have to have nurses, we have to have respiratory therapists, for instance, pharmacists, everything else. You can't just, you can increase ICU beds, but you can only increase ICU beds if you have people that will staff those beds. And as those people get sick, or if they, worst case, they are falling, very ill or dying from this illness, then how do you generate other people that can work on that? And so one of the things that we've looked at doing is having, say, other anesthesiologists that are not critical care trained to work as critical care staff, having our nurse anesthetists to work as ICU nurses, same with the PACU nurses. So there are ways you can bring people up and get them to do these kind of jobs, but it takes, again, planning ahead of time. Briefly, I just want to talk a little bit before I'm done here on ICU management. Realistically, there's nothing that's special about a COVID patient from an ICU standpoint that we don't have when we're taking care of a patient with general acute respiratory distress syndrome. So these patients have, bad hypoxia, hypercarbia. We're going to do the standard things that we do as far as intubation, if necessary, delivering oxygen with low tidal volume ventilation in an effort to stabilize them. What's come out of China and some other places and in Italy has been the use of high flow nasal cannula in a lot of patients because of their severe hypoxemia. We can give them high flow nasal cannula and increase the oxygen, allowing them to do better before we intubate them, or hopefully not intubate them. Prone position has seemed to be very useful for this disease. Prone position has kind of come in and out of favor within the ICU. Lately, it's been a little bit more useful, or we found it more useful. We're thinking is very useful for this disease. And there are some places where they've actually put patients on awake proning. So they're on high flow nasal cannula, and they just prone themselves to allow themselves to increase their oxygenation while they are, in an effort to stave off intubation. We do know with acute respiratory distress syndrome patients that limiting fluids is useful. And in this particular disease, we find that it's probably quite useful. And the recommendations are to keep these patients more on the dry side and actually probably get them a liter, or say half a liter to a liter negative every day. And then ultimately, we're going to limit aerosol producing procedures within the ICU, non-invasive ventilation, tracheostomy, bronchoscopy, those kinds of things that are going to potentially put others at risk. Finally, again, as I want to finish off with this thought again, that we are all resource poor countries here. We need ICU space, we need equipment, we need trained personnel. I'm happy to talk more about some equipment and how do we bring on more ventilators online, but we have a massive shortage of ventilators, and how do we stockpile those? So thank you so much for allowing me to talk, and I'll take any questions you have. Excellent.
I really enjoyed that talk, and luckily we actually didn't go down throughout that whole session, which is great. I'm going to close out that session, and I'm going to start asking questions, and I start looking at there's a good number of questions there, but just real quick for the audience that may not be doctors, what does prone position mean?
Oh, yes, absolutely. So normally when we put patients in the intensive care unit, we put them on their back, or what we call the supine position. And what we find with patients that are sitting on their back for a long period of time is those dependent, the downward portions of their lung tend to get worse over time. Fluid kind of drains by gravity down to these back portions of your lung. If you flip somebody over and put them on their belly, and that's the prone position, so now I'm laying on my stomach, then it kind of changes the dynamics within the lung and allows oxygenation to be better for a while. Over time, that gets worse again. And so usually you can prone somebody for about 12 hours, and then you flip them back over again, sometimes 18 hours, but you have to go back and forth. There are special beds that allow you to kind of rotate somebody, almost like they're on a rotisserie kind of thing. They're very nice, they're very expensive, and they're very rare. So most places are just flipping patients back and forth.
Yeah, every half hour, every hour.
Usually that you stay. No, actually, you stay down. Once you flip somebody, you'll stay there for 12 hours, even up to 18 hours. It takes a while for that. You'll see the oxygen level get better almost immediately, and then it lasts for up to 12 to 18 hours. Once it starts to go back down again, that's when you flip them back over.
Got it. The question that came up next is, are you cross-training personnel so ortho can do other jobs? And that in context is a really great talk coming up in one of the technology companies that has a platform which allows you to train people very quickly, real time, by sharing videos and content to the people who need to see it, and connecting the teachers to the learners. It's you don't want to miss that. We'll be coming that up later in the day. But in terms of cross-training people to assist in the ICU, how is that going?
So what we're doing at this point, especially at UCSF, is we have kind of an abundance of ICU physicians. So that we are lucky in that standpoint from a lot of other hospitals. But we are already looking at a plan to how do we cross-train people. And our first line of cross-training will be taking residents from other specialties and bringing them in and having them work as ICU physician, resident, fellow kind of thing under an ICU physician. We could do the exact same thing with other attendings as well. None of us, we're all physicians at the end of the day, and we can do this kind of care. So that really comes down to having people that can kind of run through these protocols and manage these patients. And I think that gets down to also in places where you don't have as much, say, critical care footprint, you can do. So the other thing that's being looked at is bringing other physicians into the ICU and do more kind of ICU medicine, where you can call a ICU boarded physician somewhere and they can give you advice on what to do with your patients.
Right. Well, also, there's also wonderful platforms that have actually connected hospitals and ICU so that where the experience may not be present, they have this material, they have the staff, they just need some help, and they can be supported by an ICU intensivist remotely. So that's one of the big wins in the telehealth space.
Absolutely.
Let's talk about fluids real quick. You mentioned they need to be run dry. A couple of questions on the Q&A session around spinal anesthesia, which would be the obvious go-to for a lot of lower extremity, below the abdomen sort of procedures in orthopedic surgery. We can do those with a spinal anesthetic, which makes the legs kind of go numb. But we also know that the first thing the anesthesiologist does is throw 2 liters of fluid into the patient to get the blood pressure up, because that spinal does decrease the peripheral pressure in the system, so that the fluid goes down there. And I'm being a little very poorly worded answer to that one, but how does anesthesia and fluid management and spinal anesthetic in this context play?
Yeah, so that's a great question. So in the non, like, even if you're COVID positive and you're not sick, right? So when I'm talking about really aggressively, tightly controlling fluid management, those are patients that have acute respiratory distress syndrome. So they are in the ICU with horrible hypoxia. That patient probably is not going to be having much in the way of other procedures done unless they are truly life-threatening at that point, because their more life-threatening problem is their lung disease or their cardiac disease. Even if you're COVID positive but you're doing okay, then I would say that spinal anesthesia is great. Even if you do have to give some volume to that patient, then the anesthesiologist should give the minimum volume necessary. They can also use some other ways of increasing blood pressure through some pressors during that time, just so that they don't flood the patient with a ton of volume. And then, you can give a diuretic afterwards and get that volume back off that patient pretty quickly after the procedure. So spinal anesthetic's nice. The only caution I would have with that really is if that patient is positive or if they are undergoing investigation, you just got to be sure that you're not doing something to the airway during that time. Because a lot of times we'll give them some oxygen or whatever. But if they start getting a little bit too sleepy or something, then we end up, putting them on some sort of like a mask or something like that. And that's, we don't want to do. So in that case, I think less sedation and just more spinal anesthetic, like you might see, say, again, in the developing world, that you'll see that. I think that's more useful.
In fact, that question was partly asked by our friend Dr. Aditaloye, who is a primary top orthopedic surgeon in Nigeria, especially asking that question. So let's talk a little bit about steroids. In orthopedics, we've been using steroids more frequently now. It seems to help a lot with postoperative nausea. It helps a lot with postoperative pain management, actually. But I've heard that steroids are probably not a good medication in the context of interstitial lung disease like COVID produces. Can you talk a little bit about the use of steroids in the
Absolutely.
Yeah.
Absolutely. So one of my mentors when I trained in anesthesia and critical care, Dr. Michael Mathey, said that, look, studies come and go, but steroids never die. And this is for interstitial lung disease and everything. And yes, we would love to see that steroids would work. It would make sense that steroids would work from a patient that has bad lung disease, because a lot of what happens is the body's own immune response to the infection, right? That's what causes all the damage in the lungs. Yet in every study after study, steroids don't work and actually can be harmful. So we think that for this, no different than if you have come in with community acquired, say, pneumonia, we would not give you steroids. The same thing here. Steroids they're such a large weapon, if you will, against what's going on in the lung, that they kind of knock everything down, and you need some immune response to survive this. So I would say no steroids for patients that are in bad ARDS. Fine for other procedures, but if you're in ARDS, we should avoid those.
Okay, so the patient is positive, otherwise doing well, not currently ARDS, coming to surgery, needs a little steroid. It's not the end of the world. It's only
Not at all.
sick. Okay.
Absolutely, totally acceptable to give that.
Great. That Zachary Child is very interested in this issue of N95 masks versus the standard mask. It's been answered in pretty much all the previous questions. So obviously it's in people's minds, but the role of the mask that was just previously described was largely to protect others from being contaminated. But anesthesia is a particular risk because they're intubating. So that's the reason we only use N95 masks for anesthesia, and the rest of the team doesn't need them. Is that correct? That's
absolutely correct. If you are at the airway, if you're conducting I think cardiologists, some cardiologists are saying when they're doing transesophageal echocardiography that they should be wearing an N95. They're at the airway at a patient who's awake, who could be coughing and spitting, and they want to avoid that. So anytime that you're dealing with the airway, then you should probably have an N95 mask. What we do is we put an N95 mask on and then put another surgical mask on over the top of that to protect our N95 mask. So if I get stuff on it, I keep my mask clean and I can take that surgical mask off and just replace it. And that allows us to keep our N95 masks, essentially uncontaminated. But I think that even that, for non-COVID positive patients, there's a lot of debate whether or not you really, even the anesthesiologist needs an N95 mask, but that's currently what most people are doing.
Couple of great tips there. Save your mask by putting a secondary mask on top of it. And just to reiterate this issue that the mask is primarily to protect others in the context of a normal environment, but unless you're dealing with an airway or a very high situation, you could get aerosol directly into your oropharynx, then that's the only real reason to use a higher level mask. And of course, potentially facial screens as well.
Absolutely, right. So if the N95 mask doesn't fit you, most people should be fit tested to make sure that they have that mask that works well. If that doesn't work well, then there are other devices like PAPRs, these positive airway purification devices that people wear. They're kind of similar to what orthopedists wear when they're doing total joints, but it provides positive pressure that kind of blows out. They seal tighter than those, but it's a positive pressure that blows out that allows you so that anything that comes at you will be blown away from you.
Awesome. Okay, another great question. The idea of splitting a ventilator. I think we'll talk about it as well in the next session with the design teams, because that was a hack, really, wasn't it? A hack of that happened in Europe when they're in Milan or in northern Italy when they were trying to figure out how to come up with the fact that inadequate number of ventilators. Want to talk about that a little bit?
Absolutely. So that's kind of an interesting thing that they were doing in Italy, where they were taking two patients and splitting a ventilator for these two patients. And it's possible to do. You have some, you have to make sure that you have adequate filters on both of the circuits so that the patients aren't cross-contaminating each other. Now, technically, these patients should only have COVID, but one of the things I just want to caution with this is one of the things that patients get from COVID is also bacterial infections. So you do need to treat them with antibiotics, and they could have separate bacterial infections. We don't want cross-contamination. Ultimately, the patients have to be relatively matched for the compliance of the lungs. So that when I give whatever tidal volume, half of it goes to one patient and half of it goes to the other patient. If one patient's lung is much more stiff than the other one, it's going to go to the lung that's easier to inflate. And so you'll overventilate one lung and one patient and underventilate the other patient. So it requires a lot of work, and you'd have to watch those patients very closely to do it. It is something that could be done. I would say that that would be last resort. But, one step ahead of like just just having somebody bag ventilate a patient for days, which has been done as well in Italy, that was going on as well.
Sorry, the masking questions keep coming up. I guess there's different recommendations as one would expect in a situation like this. But I just want to, Dr. Child brings up the fact that the ACS, which I presume is American College of Surgeons, recommends that N95 masks be used for all aerosolized procedures and includes electrocautery. Now, that said, on our previous talk with the ID folks, it was also mentioned that this virus really lives in the lungs, and if you're aerosolizing tissue that's not lung tissue, the risk is theoretical.
Yeah, right? I think again, this is everything's been a moving target as far as what we should be doing to protect ourselves from the patient in this case, and what should surgeons be using. There have been some people have thought, well, yes, if I'm, this virus is a patient essentially viremic with this disease, and at some point they probably are for a short period of time. It's hard to know. Could you get sprayed with virus particles during this time? Everything I've seen has shown that that's probably a very, very unlikely event. Ultimately it comes down again to what the practitioner feels that they need to do to protect themselves. I would say, as if I was a surgeon and I was in a procedure where I thought I might get sprayed with blood and I'd be very worried about this patient, then I could see myself wearing an N95, again with a surgical mask over the top of it, so that if I did get contaminated, I don't just then throw out my N95 or have to halfway during this case. I could remove that outer mask, put a new one on, continue my operation, and even save it from one patient to the next. But it's a tough thing. The other thing that comes up with this, and I know this is an orthopedic course, but for gastroenterology, that they have the same issue with. So any mucous membrane can put out virus particles. So they're seeing when they're doing colonoscopies and stuff like that, there's a recommendation that they actually wear N95 masks as well.
Moving back to the ICU environment, what percentage of people placed on respirators survived? Lynn wants to know.
I don't have the exact numbers on that. Basically that depends on place to place and age to age. What we're currently seeing right now is that I think in China, they were saying that 80% of people that were over the age of 60 that got severe illness died. Severe illness being that I am in severe ARDS on a ventilator. So it really depends on, I think a better question is what age group you are in and where you are. So the other problem that we've had is that some of the data that has come out of China has been suspect as far as what's actually, how many patients they have, what the denominator was of how many patients got infected, and then even the numerator of how many patients have died. Italy's probably a better country to look at to see how their infection has gone, and same with New York City. We do know that patients can be on this illness. If you survive, you're going to be on the ventilator for probably up to 2 to 3 weeks before you start to recover.
Weeks is long.
Weeks,
time.
Yeah, long time. So it's going to. That's bad in a lot of ways. One of the things is that you're going to occupy an ICU bed, a ventilator, and a lot of personnel for that entire time.
Around that issue, in what a blog I read from Italy was that rather than intubating patients, they're suggesting putting a tracheostomy. So a trach is easier to manage than a tube. Any thoughts about that as anesthesiologist and ICU intensivist?
Yeah. So globally, I would agree that a trach is much easier to manage than an endotracheal tube. I think you just have to be wary of, if you already, normally we're just going to intubate a patient once a patient comes in. And once, if they're stable with an endotracheal tube, it may be best to just leave them in with that endotracheal tube rather than perform an airway surgery on a patient who is potentially going to infect the surgeon, who is doing that procedure. So while tracheostomies are really nice to have, they're easier to take care of, they're more comfortable for the patient, I think that has to be tempered with safety of the person who's actually doing that procedure.
Thank you. There is one question that actually, in all the previous questions, I didn't see answered. You may not be the right person to ask this question, but let's see. Can anybody comment on the role of the inoculum size on the severity of a contracted case? In other words, you happen to be infected by somebody who's early on their infection, the viral load that you inherited, that you brought into your system is relatively low, versus being ENT doc putting tracheostomies into people and being exposed to the airways over and over again. Do you think there's a difference in how the patients respond to that viral insult?
That's a great question, and really outside of my area of expertise. I would think, what would probably make a big difference too was that person's underlying health, right? Their age, do they have underlying comorbidities, everything else, how well they're going to handle it. But I really don't know, and I don't even know if many people do know at this point how big of an inoculum you need to actually get an infection. If you get it from multiple patients, that's another thing that people are talking about. Is it somehow different? Is that a higher risk for you? It's hard to know.
Yeah, I didn't mean to put you on the spot there, but it was worth discussing. So
yeah,
in the last couple of...
it's a question I've wondered, because we have wondered in our field, if I'm exposed to multiple different patients, for instance, does that make a difference versus just getting exposed to one patient? Is there a difference coming from other patients? And probably not, but we don't know that yet.
Yeah, and just to clarify for the audience who may not be following us closely, these viruses have a very, they're kind of unstable, a habit of changing over time. The DNA can change, therefore the way they look to the immune system can vary. And so you may have developed immunity to one virus, but it suddenly changes one little protein on its surface, and suddenly your body doesn't recognize it. Did I get that right?
Yeah, that's my understanding as well. I mean, these are essentially like an RNA virus. And so I think, even with HIV, we found that people did worse when they had, if they were having, say, multiple sexual partners, because they could potentially contract kind of multiple isolates of HIV. That's my understanding, but that is way out of my, above my pay grade.
So listen, we're going to close this out. I think that the most common question that kept coming up over and over again in all these sessions, I was very concerned about contracting the virus, the role of masks, distancing. So let's just review it one more time. Who should wear the N95 masks? Who really, from everything we know about this, really doesn't need to wear it? Maybe what situations are the ones where the N95 makes the most sense? And also the question of how far away do we need to really stay in order for the aerosols to not be problematic for us? You can answer those four in the last 2 minutes.
Yeah, absolutely. Okay. So let me just state back one thing. When we intubate patients in the operating room right now, what we are doing is we're kicking everybody out of the room except for the anesthesiologist who is going to be intubating that patient. So that kind of gets at, okay, let's minimize the exposure of everybody else during these high-risk procedures. In that case, I'll be wearing an N95 if I think that patient is positive or potentially positive. There are cases that I do where the patients, like lung transplants, a lot of the transplants, we've already ruled the patient out. We've ruled the donor out. They can't get a transplant if they're positive. We know they're negative. There is some false negatives, yes. But in that case, I don't necessarily even wear an N95 because I'm not so worried about it. But for the standard patient, I'll wear an N95 with another mask on top of it. do my procedure alone, or as alone as I possibly can. And then we wait 15 minutes for the air to circulate multiple times within the operating room to bring people back in. Same with the ICU. We'll kick everybody out that we don't need to be in there, intubate the patient, and then allow people to come back in afterwards. Who needs to wear N95s? I think anybody who's around the patient, directly caring for the patient. Certainly you need it when, N95s with eye protection. That's the thing. You can get splashed in your eyes. So either goggles or a face shield or something like that. If you're doing these high risk aerosol generating procedures, that you definitely need. Other people that are in the room taking care of, in the ICU, everybody, if we have a COVID positive patient, anybody that goes in and out of that room wears an N95. I think that's reasonable. For the operating room, if they are just for the standard risk patient, then I think it just needs to be the anesthesiologist or somebody who's working directly at the airway needs it during those times. The surgeon should not really need it. If they want to wear one, absolutely they can. Wear a mask over the top of it. You can take that off. You can save your N95 from day to day. That's fine. And that's what we're doing. And that's what the CDC recommends. Now, how often do you need to then change that mask? That's up for, nobody really knows.
That's great.
Yeah.
Great.
Yeah.
Thank you. Thank you so much. It's been an absolute pleasure to hear from you. You've given us great insight, and I'm going to now close out the session. We're about ready to move into our next meeting. It's going to be an extraordinary and probably a little ground-changing meeting, because we're going to be meeting with IDEO. IDEO is probably the world's most important design firms that came up with the whole idea of design thinking. They designed the very first Apple mouse. They're going to meet with us, talk to us about how the design community is going to engage with orthopedics and the surgical community at large. And they're going to then go and ask our audience for ideas as to things that they can solve. Go and do basically a design-a-thon, a hackathon over the next day and a half, and meet up with us at the end of Friday to share with us exactly what ideas they've come up with. So we're super excited for that. And I'm be calling the session an end. Thank you very much, Dr. Campbell, Professor Campbell. It's been a pleasure talking to you. And I'm going to call it a day. And
My pleasure.
thank you again.
Thank you. Thank you.
Thanks, everybody. Their questions too. Bye.